after the age of 40, 45,
Yeah.
then we should
Then you
explore
should-
the endometrium.
Yes, yes. Yes,
Okay.
ma'am.
है तो नहीं बोल रहे हैं, लेकिन 45 के बाद तो रिपोर्ट करने के लिए बोलते
Okay.
हैं।
We were not
endometrial
aware about
करना
that.
है।
We'll start doing that now. Thank you.
Thank you, everyone.
हाँ वही मतलब कुछ उसको है कि
I would like to call on Dr. Vandita Singh ma'am to give her a talk on how the Bethesda system of reporting is being used in squamous cells and glandular lesions. And I would like to briefly introduce her. She is currently an additional professor working in the Department of Pathology, AIIMS Raipur, and she has done multi-institutional international projects under ICMR. She is also a fellow of neuropathology from CMC Vellore and has a special interest in neuropathology and molecular pathology. Ma'am, please take the dais.
Thank you. Good morning to everyone. I just want to make a small correction. I'll only be discussing glandular lesions as HCL and squamous cell carcinoma sir has already covered very well. So since the CME is about liquid-based cytology, we should know what are the differences between conventional pap smears versus liquid-based cytology. Liquid-based cytology definitely has a lot of advantages over conventional smears, which are they can be thick. There'll be a lot of background material and artifacts, which are gotten rid of in liquid-based preparations. Also, when you make a base smear, there is a standardized method for cervical specimen collection, for processing and screening. So the false positives and false negatives as a result are much lower when you use liquid-based cytology. And because of this, using LBC, there is an improvement in the detection of precursor lesions of cervical neoplasia, because after collection, immediately you put the material into for wet fixation. That preserves morphology very well. So in our department, we use the SurePath system. And in the collection vial, the residual material can be used for ancillary testing. And in higher centers, you can use digital pathology in the form of BD, focal point, slide profiler, and focal point GS imaging system for digitally screening these LBC slides. The diagnostic criteria in liquid-based cytology are similar to those applied for conventional cytology, but we have to get familiar with alterations in the background, extracellular elements, architecture, and cell morphology that occurs when we use a liquid-based cytology system. Now, here we are focusing on 2014 Bethesda system for reporting cervical cytology. So before we begin reporting on the glandular lesions, all the prerequisites have to be met. So in a report, you have to mention the specimen type, whether it is processed via conventional smear or liquid-based system, and you have to report all the quality indicators. That includes cellularity as well as presence or absence of endocervical transformation zone and at least 10 well-preserved endocervical or metaplastic cells. So absence of transformation zone does not necessitate repeat testing, but it has to be mentioned in the comment. Now, in an LBC smear, you're looking at squamous cell abnormalities as well as glandular cell abnormalities. Amongst squamous cell abnormalities, the important diagnostic criteria are categories are atypical squamous cells, L cell, H cell, and squamous cell carcinoma. In the glandular cell abnormalities, the major diagnostic categories are atypical glandular cells, adenocarcinoma in situ, and adenocarcinoma. Out of the three categories in glandular cell abnormalities, the atypical glandular cell category is the largest. And these atypical glandular cells, 30% of these lesions are associated with high-risk HPV. So 30% will have high-risk HPV types positive. When we give a diagnosis of atypical glandular cells in cytology, it means not just glandular abnormalities, but other differentials as well. So a diagnosis of AGC on histopath will subsequently in 15% of cases turn out to be a intraepithelial, squamous intraepithelial lesion, L cell or H cell. 1% will be recategorized into the adenocarcinoma in situ category. and 0.5% will turn out to be adenocarcinoma. So the biggest category is atypical glandular cells. Now, this is the algorithm for making a diagnosis of a glandular lesion. So what are these HCGs? HCGs are hyperchromatic crowded groups. So these are three-dimensional glandular clusters, which are more often seen in liquid-based cytology compared to your conventional smears. So on an LBC system, you have to first notice these HCGs. After you look at the HCGs, you have to look for nucleoli in these glandular cells. If the nucleoli are absent and they are glandular cells with elongated nuclei, cigar-shaped nuclei and coarse chromatin, then more likely the diagnosis that you have to give is adenocarcinoma in situ. Okay. If nucleoli are present, then you have to look at the chromatin distribution. If the chromatin is dark, irregularly clumped, irregularly distributed with parachromatin clearing, you have to keep in mind that it can be still an early invasive squamous cell carcinoma. Now, in the other nucleoli present with peripheral distribution of hyperchromatic coarse chromatin, then you have to look at other non-adenocarcinoma in situ glandular lesions. The algorithm further depends on the nucleus size. In the nucleus size, you have to see if the nucleus size is less than 3 times the size of intermediate cell nucleus, 3 to 5 times the size of intermediate cell nucleus, or more than 5 times the size of intermediate cell nucleus. If it is less than 3 times the size of intermediate cell nucleus with a nucleolus, more likely this is reactive. So it can be because of exfoliated endometrial cells, directly sampled endometrium, area stellar reaction, microglandular hypoplasia, and several others. If the size of the nucleus is 3 to 5 times the size of intermediate cell nucleus, only then you can call it on cytology atypical glandular cells. Now, these atypical glandular cells, you may or may not classify depending on what you are seeing on the morphology. If you can classify them on morphology as endocervical, you call them atypical glandular cells, endocervical, NOS, or favor neoplastic based on further features, or endometrial, atypical endometrial cells. Sometimes you cannot make this distinction between endocervical, endometrial, or any other kind of atypical glandular cells. Then you put it into the category of atypical glandular cells, NOS, not otherwise classified. If the nucleus size is more than 5 times the size of intermediate cell nucleus, then it is an adenocarcinoma on cytology. What are the other features which will help you in making a diagnosis of adenocarcinoma on cytology? The cells have to be, the nucleus has to be large with a large nucleolus. So whenever you see a large nucleolus in a cell which is more than 5 times the size of an intermediate cell nucleus, please call it an adenocarcinoma. Associated features you can look for are tumor diathesis. So we start with this algorithm and we'll discuss each entity in details. So before we start looking at atypical cells, let's revise what normal cells look like, these glandular cells in a cervical smear. So you see endocervical cells in a normal cervical smear. What are these like? These are tall columnar cells. They have a wispy, not working. Pointer's not working. Okay. I'll just use the mouse. Can you see the mouse? Yeah. So they are tall columnar cells. They have wispy cytoplasm at the base. And when they are on their end, they have a picket fence appearance. And when they are on their face, then they have a honeycomb appearance. So this is a normal endocervical cell. On the other hand, what would an atypical endocervical cell look like? The atypical endocervical cell will be enlarged 3 to 5 times the size of an intermediate cell nucleus with or without prominent nucleoli and with minimal architectural disorganization. And what do the other glandular cells in the cervical cytology look like? Normal endometrial cells. Now, these normal endometrial cells are commonly seen in young people or in the proliferative phase. However, when these cells are present in a person who's more than 45 years of age, you have to report them, because even if they look normal and benign, by protocol, you have to sample the endometrium. So endometrial cells compared to endocervical cells, how do they look different? The normal cells, there are tight hyperchromatic three-dimensional groups with small nuclei. Can you see this? This is an intermediate cell nucleus. So this is almost the same size as the intermediate cell nucleus, or slightly smaller than that, hyperchromatic. And if it is seen, if this similar picture is seen along with some spindled elements which represent endometrial stroma in a more than 45-year age group, then you have to do endometrial sampling. Now coming to the Bethesda reporting system for glandular abnormalities, basically there are three broad groups. One is atypical glandular cells, next is endocervical adenocarcinoma in situ, and the last is adenocarcinoma. Amongst the atypical glandular cells, that you have the NOS category and the favor neoplastic category. The NOS category, atypical glandular cell, endocervical NOS, atypical glandular cell, endometrial NOS, or atypical glandular cell NOS, when you cannot site specify it as being cervical or endometrial. In the favor neoplastic category, you can have atypical glandular cell, endocervical, or just atypical glandular cell, favor neoplastic. Notice here we don't have atypical endometrial cell favor neoplastic. We don't have, because the atypical endometrial cell is very difficult to put into category of atypia favoring neoplasia. There are a lot of mimics, which we'll discuss later. The next category is endocervical adenocarcinoma in situ, and then adenocarcinoma. Again, in adenocarcinoma, you have to try to site specify it into endocervical, endometrial, extrauterine, where you can identify the site, like the fallopian tube or the ovary or the intestine, then you specify it. However, if you cannot specify it into endocervical, endometrial, or specific site extrauterine, you put it in NOS or not otherwise specified. Now, this is just a hodgepodge of sample reports or for the pattern of reporting atypical glandular cells. This is from Bethesda, which you can look up. So this is just to give you an idea of how it is reported. Always, first is quality indicators. First is adequacy. You have to report whether it is satisfactory for evaluation or not. Transformation zone is present or not. Put it into its general category for glandular lesions, which is epithelial cell abnormality glandular, and then interpret it into its subsequent subcategories, which can be atypical endometrial cells present, not otherwise specified, etc. So this is a pattern for reporting. Now we look at the cytomorphology of all the lesions that I have listed down. So the first is atypical glandular cells, endocervical, not otherwise specified. What does the morphology on LBC look like? Basically, you have atypical endocervical cells. How do you define these atypical endocervical cell? There is mild nuclear enlargement, 3 to 5 times the size of a normal intermediate cell nucleus. What are the other abnormalities? There will be overlapping of the nuclei, pseudostratification, variation in size or shape, hyperchromasia, chromatin irregularities, rare nucleoli, and mitoses. But this atypia is beyond that for reactive or reparative changes. There, the nuclear size has to be less than 3 times the size of intermediate cell nucleus. Okay. Now, and what are the other thing? On the lower spectrum, it should be more than the size of a reactive nucleus, and on the other extreme spectrum, there should be without any definite features of adenocarcinoma in situ or invasive adenocarcinoma. All right. Again, this is another example to compare what do AGC endocervical NOS, how does it look different from a reactive endocervical cell? So on the right side, you have reactive endocervical cells. These nuclei are less than 3 times the size of an intermediate cell nucleus. This is the intermediate cell. So this is less than 3 times that. Whereas here, the size is definitely more than 3 to 5 times. Okay. It is also hyperchromatic. Where you know the reason for the atypia, for example, in this patient radiation, you can put it in the comments that there was history of radiation given to this patient. Most probably this atypia is related to radiation. So you have to qualify the atypia. You have to give a reason wherever possible. Next, you have atypical glandular cells, endometrial NOS. Now, compared to your endocervical cells, the endometrial nuclei are smaller. what you have is small groups of endometrial cells. These have enlarged nuclei. How will you do the comparison of the nuclear size in this? Now, an endometrial cell nucleus is almost equal to the size of an intermediate cell nucleus. So it's only a little enlarged, maybe 2 times the size. Enlarged nuclei, mild hyperchromasia, chromatin heterogeneity, occasional small nucleoli, scant with or without vacuolated cytoplasm, and very importantly, ill-defined cell borders. Endocervical cells very commonly show proper cell borders. In endometrial, you will not find these cell borders. So how will you screen? When you screen your slide, you have to identify hyperchromatic crowded group and then try to fit it into endocervical, endometrial, extrauterine or others. Okay. So when you see this HCG, when will you suspect endometrial origin? Nucleus size larger than normal endometrial cells, twice that of a normal intermediate cell nucleus. The nuclei may show nucleoli. And in this case, the histologic diagnosis was well differentiated endometrioid adenocarcinoma grade 1. Now, this is another example of AGC endometrial cells NOS. What you see here is a hyperchromatic crowded group, which is a 3-dimensional cluster in the LBC. Okay. What else do you see? Although this picture is not doing justice to it, there are nucleoli in this. And there is a cytoplasmic vacuole, which is pointed by the arrowhead. And the histologic follow-up in this case was endometrial intraepithelial neoplasia. Now, this next category is atypical glandular cells, NOS, not otherwise specified. So we try to categorize by site wherever possible. But when you can't, you put it into the category of NOS. This category is used when you're unable to distinguish between mildly atypical endocervical and endometrial cells. Then we have the next subcategory, which is atypical glandular cells, favor neoplastic. So we look at the first subcategory in this, atypical glandular cells, endocervical, favor neoplastic. What is the cytomorphology in this? As you can see in this picture, you have atypical endocervical cells, which have nuclear atypia, nuclear elongation, plus minus glands or rosette formation, but the atypia is quantitatively or qualitatively less to make a diagnosis of adenocarcinoma in situ or invasive endocervical adenocarcinoma. Matlab, if you had more of these clusters, you would make a diagnosis of AIS or adenocarcinoma. If you have less of these clusters, then you put it into the category of AJC, endocervical, favor neoplastic. So in this picture, you can see 3-dimensional groups of endocervical cells with enlarged nuclei. The size of the nuclei is 5 times the size of intermediate cell nucleus. So in our algorithm, when the nucleus size was more than 5 times, you put it into adenocarcinoma. But because maybe the clusters are less in number, we put it into the category of favor neoplastic, AGC, favor neoplastic. Then we have AGCs, endocervical, favor neoplastic, another example. Now, in all reports, not just in cytology, but in this cervical cytology, but every cytology report, the importance of comments cannot be emphasized more. So wherever you can qualify something, you must explain. So for example, here too a diagnosis of atypical glandular cells, endocervical favor neoplastic was made. But a comment was added that definitive interpretation is limited due to poor preservation. As you can see in this, it's kind of smudged chromatin. The morphology is not very, very clear. So whenever you give a diagnosis of atypia, please qualify what the atypia is because of. Maybe it is a preservation artifact. So put it in your comment. Then we have the next category, which is atypical glandular cells, favor neoplastic, where you're not calling it endocervical. You're not typing it. So whenever you are unable to distinguish between atypical endocervical and endometrial cells, or the features are insufficient for a diagnosis of in situ invasive adenocarcinoma, you put it into AGC, favor neoplastic. Then we come to the next big category, which is adenocarcinoma in situ. So this endocervical adenocarcinoma in situ, or AIS, what does it look like in your LBC? In your LBC, there will be groups of cells and clusters, pseudo-stratified strips and rosettes. You can see here there is some pseudo-stratification. There are elongated cells which are hyperchromatic. So there is definitely nuclear crowding, enlargement, hyperchromasia, coarsely granular chromatin, but inconspicuous nucleoli. pseudostratification, apoptotic bodies, and mitotic activity in a clean background. So why do we make this, why do we focus on the clean background? Whenever there's tumor diathesis, it is possibly a higher grade lesion like an invasive adenocarcinoma. So all of these features together, it's very, very algorithmic. Okay. So here you can see hyperchromatic crowded groups, cells exhibiting high NC ratio, elongated cigar-shaped hyperchromatic nuclei without nucleoli and without tumor diathesis. This makes a diagnosis of AIS on cytology. But you must remember 50% of glandular lesions have a coexisting squamous intraepithelial lesion. So just because we found a glandular lesion, don't forget the squamous cells. Just because we found a squamous lesion, don't forget the glandular cells. So this is an example of adenocarcinoma in situ with high-grade squamous intraepithelial lesion. And this will help you in distinguishing between atypical squamous and atypical glandular cells. Okay. So you can see in this smear, the AIS cells on the right and the HCL cells on the left. Okay. So the AIS cells exhibit nuclear atypia, nuclear enlargement, hyperchromasia without nucleoli, which is similar to that seen in HCL. But the nuclei are cigar-shaped. They have lacy cytoplasm compared to the HCL cells, where the cytoplasm is more dense. So the more and more you keep observing this morphology, you'll be able to appreciate what is dense cytoplasm and what is lacy cytoplasm. All right. Then we come to the last category, which is adenocarcinomas. Now, so important subgroups in adenocarcinoma are endocervical adenocarcinoma, endometrial adenocarcinoma, extrauterine adenocarcinoma, where you can identify a site, ovarian, fallopian tube, rectal, etc. And then others where you cannot put it into any category, which is NOS. So how will you differentiate between all of these glandular carcinomas on cytology? By looking at cellularity of the smear, pattern, tumor diathesis present or not, cell shape, nuclei, cytoplasm, coexistent squamous intraepithelial lesion or carcinoma, high risk HPV present or not, and IHC with P16, which can be done on cell block prepared from the preserved preservative fluid. So if you compare all of these, you can see in the endocervical adenocarcinoma, the cellularity is most. It is hypercellular for obvious reasons, because that is being sampled directly. Tumor diathesis is present in all, but it is visible more often in endocervical carcinoma. Cell shapes. Endocervical carcinoma, the cell shapes are generally oblong. The nuclei are elongated to oval compared to endometrial and extrauterine carcinomas, but this can be variable. Then we go look at coexistent squamous intraepithelial lesions. These are present in 50% of endocervical carcinoma. So agar squamous lesion aa raha hai or glandular abnormality hai, think of endocervical origin, endocervical adenocarcinoma. High risk HPV is positive in most endocervical carcinomas. It is patchy in endometrial carcinoma and variable in extrauterine depending on type. P16 immunohistochemistry is block strong positive in endocervical carcinoma. It is patchy in endometrial and variable in extrauterine carcinomas. Now we look at the morphology of each of these in details. Okay, so this is adenocarcinoma, endocervical. What you see here is a honeycomb pattern of cells. So you make out it is endocervical. What is very, very conspicuous is, can you see these nucleoli punched out, round, big nucleoli? So what you have here is cytologic findings seen in endocervical adenocarcinoma in situ with macronucleoli with features suggesting invasion, namely tumor diathesis. So three main points. It has to be endocervical, very pleomorphic, macronucleoli with tumor diathesis. This is how you will make a diagnosis of adenocarcinoma endocervical. Then adenocarcinoma endometrial. Endometrial cell groups, HCG groups, are much more tighter compared to endocervical. So you have single or small clusters of cells with variation in nuclear size, loss of nuclear polarity, hyperchromasia, chromatin clearing, prominence of nucleoli, and scant vacuolated cytoplasm. But in addition, you can also find intracytoplasmic neutrophils, as this arrow points. Okay. Now, in this particular sample, how will you go in the algorithm? First, you identify the hyperchromatic group, crowded group. Okay. And then you look at cytoplasmic vacuolation, neutrophils present or not, size of the nucleus, and type it as endometrial. Now, making this diagnosis of endometrial adenocarcinoma is very difficult in a cytology smear. You have to be aware of this. There is going to be a lot of obscuration because of blood, or because the cluster is very, very tight and you can't see the center, you can't identify the nuclear features, or it may be hypocellular, and several reasons. That is the reason making this diagnosis on cervical smear is difficult and not that common. Okay. Then we have adenocarcinoma extrauterine. Extrauterine matlab you don't have to leave it at extrauterine. You have to say which site: fallopian tube, ovary, breast, intestine. If you can identify the morphology, name it. Okay. These are adenocarcinoma cells. When they are extrauterine, generally there is no tumor diathesis. Then you qualify the site of origin. For example, in this is a papillary cluster. Patient had ovarian mass. So this was called ovarian serous. All right. What more can you do? If you've made this, if you've seen this on the smear, take the material, spin it, make a cell block, do IHC for further characterization. IHC can be done on LBC prepared smears as well, but it's not as good as cell block. So cell blocks are preferred. Now adenocarcinoma NOS. So now you can tell me on your own. When you cannot type it into endocervical, endometrial, extrauterine, then you put it into the NOS category. Okay. Now it does not mean that it is not endocervical, not endometrial, not extrauterine. Okay. So here what you can see in this smear is the cells are consistent with adenocarcinoma without features that differentiate, naming the site of origin. Here, ultimately, the diagnosis was a large cell neuroendocrine carcinoma. Okay. But it can also be a cervical lesion. For example, this smear turned out to be an adenoma malignum. And this turned out to be clear cell carcinoma. And this was a glassy cell carcinoma. But they were all in cytology called as adenocarcinoma, NOS. Similarly, you can have fallopian tube and others. Stuck. Now, these are the last few slides. What do you do after you make a diagnosis of atypical glandular cell on cytology? What does the clinician do? After you've called something atypical, if it is an atypical endometrial cell, then the gynecologist has to sample the endometrium, do a biopsy. Okay. On the biopsy, if it is negative, there is no pathology, then patient has to undergo a colposcopic examination, routine follow-up. If you call it atypical, but accept atypical endometrial cells, any HPV result, then the protocol is do colposcopy with endocervical sampling if not pregnant, endometrial sampling if more than 35 years of age, or age less than 35, but at risk of endometrial neoplasia, whatever are the clinical risk factors for endometrial neoplasia. So this is the algorithm that follows after you make a diagnosis of AGC. This is the algorithm of what happens if you do a diagnosis of AIS, which the clinicians will know better. So to conclude, the incidence of atypical glandular cells is approximately 0.18 to 0.74% of all cervical smears, with a reported prevalence of 2.5% amongst all pap smears. Incidence of glandular abnormalities diagnosed on pap smears has increased with greater sensitivity and precision after the onset of liquid-based cytology. A high degree of suspicion, good clinical history, presence of diagnostic cytomorphological findings are essential for proper interpretation of glandular cell abnormalities. And one must follow a methodical approach to evaluate pap smear greatly so that you can avoid the diagnostic pitfalls. So that's it. And I would like to thank HOD sir and all the people who have come, seniors as well as juniors, Rasika ma'am, for coming all the way over here. And I hope this has been useful for you all. Thank you.
Thank you, ma'am. That was a wonderful talk. We have one question from Dr. C.S. Azad from Gurugram. He asked, should we write details about the cellular changes while reporting the Bethesda system, or only the points which are cellular changes needed to make that diagnosis.
If there are any atypical features, you must definitely mention, but qualify them in your comment. Do you think it is reactive or not? Is it an artifact or not? That is the whole point of using this system. To not let anything go missing and also not to overstate anything by leaving it ambiguous. So yes, you must mention.
Thank you. Do we have any more questions? Moving on next, this is a must awaited session for today's, which is a case-based discussion, which would be taken up by our next speaker, Dr. Rasika Uday Gadkari, madam. And this is a very short introduction to her. So I would briefly introduce her. She is currently Professor and Head of Department of Pathology, AIIMS Nagpur, and she has dedicated multiple years of her service. She has a lot of experience in many colleges, in all the government colleges, and has been conducting several national levels as well as state level conferences with more than 30 publications to her name, and her principal area of interest and contribution has been in the field of cytology. And she is also currently the president of VAPM and Association of Cytologists of Maharashtra. With this, I will hand over to you, ma'am.